Well, for those that are out on the East Coast, good afternoon. And for those that are on the West Coast, good morning as well. And I apologize here. Oh, show my screen. That'll probably help if you guys are able to see what I'm seeing here. So we're good. Sorry, I'm actually presenting today from the training room here in Cypress, California, at Healthcare Synergy's office. So just a little bit of a different setup than what I'm used to, since my office is actually based in Michigan. So what we're going to be doing today is talking about the HITECH Act, which is the Health Information Technology Act, part of the Obama stimulus package that deals with EMR and EHR and how that's going to affect us in home health and hospice. Now, before I get started with the actual presentation, I would like to go ahead and ask you guys a couple of questions. So some questions will be popping up on your screen if you have the opportunity. The first one is, how long have you been using Healthcare Synergy? And 0 to 1 year, 1 to 2 years, 2 to 5, 5 years plus. And if you go ahead and answer that for me, that would very much appreciate that. And we'll wait until we've got a number of responses here. It looks like, according to our screen, we've got 74% of you have voted. So if we get 1 to 2 more to vote, I would really appreciate that. And we'll be able to go. So I see that most of you have been using Healthcare Synergy for 5+ years. And on behalf of Healthcare Synergy, I want to thank you for your continued patronage and also let you know that towards the end of this presentation, you will also see something new that's coming out here shortly from Healthcare Synergy. So the next question I have for you is, how did you hear about this webinar? And did you hear about it from our website, from an email, from a phone call, or from a friend? So if you guys could go ahead, and this is just to judge our marketing efforts. So again, I do appreciate it. And I can see that a lot of you have received this from your email. So I do appreciate. Just a reminder, about once a week, Healthcare Synergy sends out a newsletter. And that newsletter has a lot of information on it. I know a lot of times, if you're like me, you get a lot of newsletters from different organizations, different list server groups that you're on, and things like that. The Healthcare Synergy one actually contains a lot of information, not only about the healthcare assistant, but a lot of happenings that are going on in the current industry. So things like the PCOS delay that was just announced last week. We actually, instead of the newsletter, we also sent out an announcement about that as well. But the newsletter will also contain tips on how to use the current version of Healthcare Assistant. So a lot of times that you know that Healthcare Assistant software, there's a lot of things in there, and there's a lot of ways to do certain things. So in the newsletter, it's going to show you a tip that, hey, you never knew, but this may be an easier or quicker way to access a certain portion of the software. So the next question I have for you is just, are you currently using a point-of-care software? And it doesn't matter if it's the eClinical software or the SOS, the Bureau, or even one of our partner companies, the Care Portal application. So just to kind of gauge and to see where you're using, if you're using point-of-care software. And I can see that a majority of you guys currently are not using point-of-care software. So we'll go ahead and close that poll. And just wait for one more. If we can get one more person to vote, that would be great, so we have a good market sampling. So I can see who's being attentive to this webinar and who is not. And we'll go ahead and close it right now. So let's get on with the actual presentation. And give me one quick second. I'm just going to move something off on my screen here. And again, my name is Michael Deck. My email address is mike.deck@healthcaresynergy.com. I apologize. It looks like my PowerPoint didn't come over just exactly right. I can be reached at 714-229-8700, extension 321. Feel free to give me a call at any time. I do have a reminder for you. If at any time during this presentation you have a question, you have the opportunity to go ahead and type in that question in the question window on the right-hand side of your screen normally for the webinar. And if you go ahead and enter that question, I will get a little notification, and I will try to be proactive in answering them as soon as they come in. If not, we'll definitely go through all the questions and answers at the end of this presentation. So diving right into the presentation, let's get into the meats of this thing. So who am I? Well, I started off working in a home health care agency up in northern, and I won't say northern, but southeast Michigan, actually doing data entry into Healthcare Synergy 15 plus years ago. I joke around, I've been involved in home health care since the days before PPS. I've also, in the continuum of care, I actually built and licensed and oversaw the creation of an assisted living facility. I've been a consultant to a physicians group, an OBGYN group based in Detroit for the 5+ years. I joke around when I talk with agencies and they say, oh, you work with a physician group, oh, referrals, especially those from Southeast Michigan. Well, it's my wife's group and it's an OBGYN practice. So there's not a lot of home care and we don't see a lot of geriatrics coming in. She does high-risk OB. So we don't see a lot of geriatrics coming in there. I'm a nationwide speaker. Coming up, I will be presenting in person in Columbus, Ohio next Tuesday. And then in June, I will be back out here in Cyprus, and then also Chicago and Michigan. Also, I'm speaking at the Richard Dixon seminars, which are located, some of the information is located on the Healthcare Synergy website. That's in Hawaii in September. And a few other presentations are in the work as well. And I joke around, I'm the husband of one and the father of two in that order, just to kind of give you a little bit of my information. And of course, I couldn't do any sort of presentation without a picture of my wife and my kids, so that they are there. And actually, I joke around, technology has advanced so much that my son is actually the one that did all the background for this presentation. As we're going through, when I talk to a lot of agencies, a lot of them will look and say, well, you know what, if I install this software, it's going to make my life perfect for it. And just kind of a reminder that a software is a tool, it's not a solution. This guy getting his battery changed on his car is not going to get him out of the predicament that he's in. So keeping that in mind as we go through this, remember that software is a tool, it's not always a solution. Sometimes we have other issues at our agency that's going to take precedence over a software issue. Example, that my clinicians out in the field just do not do their work, period. Don't do their documentation. Don't come into the office. Well, giving them software, if they're not doing the paper form, maybe giving them software is not going to be a solution to that. It's going to be a tool to help them. So deadline for EHR, and I'm going to actually bring up a last poll here because I'm always interested to see what you guys think on this one. So I'm going to go ahead and launch this. And when do you think that you have, or when do you think, or when have you heard that you have to be paperless? Is it 2013, 2014, 2015? Never? I don't know. And I'm going to go ahead and wait till we get a majority of the people that respond to this, so we get a consensus up here. And 91 people have responded, so that's a pretty high percentage. And almost half of you have said that you've heard that you have to be electronic and paperless by 2014. So let's go ahead and dive into this and see if you guys are correct or not. So stepping into EHR. So we're going to be talking about EHR and EMR. And before we even begin, I want to go through because there's a difference between an EMR and an EHR. So an EMR is the electronic record of health-related information of an individual that is created, gathered, and managed and consulted by a licensed clinician and staff from a single organization who are involved in an individual's health and care. So for example, let's say I go into the hospital, the Detroit Medical Center, I'm from Detroit. I go into Carmanos, and Carmanos has an electronic medical record of the care that they provided it to me. I go to my PCP, my primary care physician, and he has an electronic medical record that goes to, that's just in his practice that deals with his care towards me. And then let's say that I go to a skilled nursing facility, because I'm not quite yet old enough for that, but maybe when I get a little bit older I will. That skilled nursing facility has their own electronic medical record. And then I go into home health care finally. And home health care has an electronic medical record. So each one of those providers that I see has an individual system that takes care and manages my health information. That's an electronic medical record. So it's dealing with an individual agency that's providing care to me. So you can guess what an EHR is. And that's where we're going to get the hospital's EMR system and the physician's EMR system, my primary care. Remember, I went to skilled nursing, so their EMR system and the home health agency's EMR. And they're all going to collectively together, they're known as the electronic health record system. So individually is an EMR system from each of the providers, but collectively grouped together, they're known as EHR, electronic health record. And a lot of people use these as interchangeable, an EMR and an EHR system. But it's actually two separate items, one being the EMR being from the single agency and one being the electronic health record, which is again collectively from all the providers. So current legislation. There is legislation out there on the books today, passed by Congress, signed by the President, that deals with electronic health records. And this title is the Health Information Technology for Economic and Clinical Health Act, or HITECH Act. And we're going to spend a little bit of time because this is the one that actually mandates the use of electronic health records. And the first thing is looking at the definition on this act. The third definition that they say is a healthcare provider. What is the term healthcare provider? And the term healthcare provider includes a hospital, skilled nursing facility, home health entity, or other long-term care facility, healthcare clinic, community mental health center as defined in section 1913B-1. So when we first look at this law, all of a sudden one of the third definitions that's going into the law says, wait a second, look at, we've got home health and we've got long-term care facility, and so we can also incorporate hospice in there. So woohoo, wait a second. Things are starting to look bright for us because there is a law in the book that mentions home health and hospice. Again, this is just the definition at the beginning of the law, so let's dive a little bit closer into the law. And what it is the government knows that they can't force you to do anything. As much as they want to try, as much as we let them, we know that they're not going to force us to use anything. So what they're doing is they're doing an incentive program. So what this incentive means is that they will give you X amount of money, a percentage more on your Medicare and Medicaid billing if you're using electronic health records. So this is all starting to sound pretty good, especially in today's environment where we had a 2% sequestering cut and we know that we're not getting our rates up. So let's dive into exactly what this incentive payment's all about. And subject to the succeeding paragraphs of this paragraph, blah, 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 an eligible professional during a payment year, if that eligible professional is a meaningful EHR user as determined under paragraph blah, 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 and using certified software, will be able to receive this incentive payment. So the big thing that I kind of want to highlight right here in this law, where it gets a little funny for us, is that it talks about eligible professional. It doesn't talk about a healthcare provider, but what an eligible professional is. So basically what that act says is if you're an eligible professional and you use certified software and you demonstrate something called meaningful use to the government, then you're going to get some extra cash. So again, we have 3 steps that we have to abide by. We have to be an eligible professional, we have to use certified software, and we have to demonstrate meaningful use. And if that happens, then we're going to get a little bit of extra money on our claims. However, now comes the monkey wrenches for home health and hospice. So number 1, where's my money? We said that, remember, there was a definition of healthcare provider, but in the law they don't use the words healthcare provider, they use the words eligible professional. And the term eligible professional means a physician, a dentist, a certified nurse midwife, a nurse practitioner, or a physician assistant. So right there off the bat, the very first step in order to receive this incentive funds was we had to be an eligible professional. Later on in the law, when it defines an eligible professional, we can see that unfortunately home health and hospice are not included in this law. So we got strike 1. My son plays a lot of baseball, so we're going to be using some baseball terms here. So strike 1 is against us. We're not going to get funds because we're not an eligible professional. Number 2 is that we had to be an eligible professional using what? Certified technology. So let's go to the definition of certified EHR technology. The certified EHR technology means a qualified electronic health record that is certified pursuant to blah, 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 meeting standards adopted under section of such act that are applicable to the type involved. So what happened when this law happened, or this law passed and was put in place, is we had what was called the Office of the National Coordinator. And the Office of the National Coordinator creates the certification criteria that us as software vendors have to develop our applications to meet in order to qualify for these incentive payments. However, the ONC, or the Office of the National Coordinator, does not actually certify the software. They just develop and the criteria, and actually just a heads up, they will also monitor the software providers that meet the criteria to make sure that they continually meet the criteria. There was just an announcement last week that the ONC is actually uncertified a software provider who turned out to be non-existent. But again, it's National Office of the National Coordinator that will actually develop the certification criteria for us as software vendors. However, they don't certify the software for us. So we as software vendors, we get the criteria from the ONC, and then we can contract with one of 6 companies that are based nationwide, and these are known as ONC authorized testing and certification bodies. So we as Healthcare Synergy, once we get the certification criteria from the ONC, we can go to SureScripts, SLI Global, InfoGuards, Drummond. We can go to one of these private companies and we can say, here is the criteria that the government has developed for us. Here's our software. We'll pay you to certify us. Now here's strike number 2 against us. In the current standing with the ONC, the Office of National Coordinator, they have not developed any criteria for long-term post-acute care software vendors. So for us in skilled nursing, hospice, home health, assisted living, we don't have the certification criteria yet even developed by the government in order to go to one of these providers. So that's strike 2 against us. Remember, first of all, we're not an eligible professional, and second of all, we don't have the certification criteria. Now, we got to have a monkey wrench in this, because if we didn't have a monkey wrench, it wouldn't be healthcare, right? So that monkey wrench is one of the private companies, which is the Certification Commission for Health Information Technology. It sounds like it's a government organization, but it's a private organization. They have developed their own criteria for long-term post-acute care providers. So it's outside of the ONC, it's outside of this HITECH Act. They've developed their own, says, hey, listen, you know what, we're going to go ahead and develop our own criteria. You can pay us $100,000 and we will go ahead and certify your software as being LTPAC approved from the CCHIT. So basically what that means is I could take my money as a software vendor, give it to them, and they give me their stamp of approval. However, their stamp of approval for long-term post-acute care does not apply to the HITECH Act. So that's a little monkey wrench in that. So sometimes you'll see, CCHIT, and they're very proactive with their marketing on it. And we actually do have their criteria as well and are working with it. But at this stage, it doesn't make sense for a long-term post-acute care software vendor, other than a marketing effort, to go ahead and get the CCHIT approval, because it's not going to apply to the HITECH Act. And this is just, again, I forgot I had the slide in here, but it kind of says it. And they started this in 2011, so 2 years ago. They developed the core program. So the final stage was, remember we had 3 things that we had to do. Eligible professional, we're not one. ONC certified software, we're not one, because there's no certification criteria. The third thing is that we, as a provider, if we had those 2, it's not just enough that we use the software, we have to demonstrate to the government that we're using it in a meaningful way. And right now, there are 2 stages that are currently on the books, called Stage 1 Meaningful Use and Stage 2 Meaningful Use. And right now in our time frame, we're following under Stage 2 Meaningful Use. The easiest way to describe it in a non-technical term is the only way I can think of meaningfully using a pumpkin is to make pumpkin pie on it. So what it is basically it's a set of criteria that the provider reports back to the government and says, I've been able to use my certified EHR as an eligible professional, and I've been able to track patients. I've been able to look at outcomes. I've been able to do things, a whole set of criteria on it. So again, we started off at stage 1. Currently, we're right now under stage 2. And later this month, we are going to see the release of stage 3 meaningful use requirements. So you may have seen something about two months ago about the National Association of Home Care endorsing stage 3. So, whoa, wait a second. Why is NAC getting involved with the HITECH Act? And what it is they are through the Home Care Technology Association of America. And you know, anytime that there's a law, there's a public comment period, right? So you can go on the website and write your comment. Hey, this law is great. Hey, I really think we should do this with the law. Hey, I approve this. Hey, I support this. Hey, I think we need to take it a step further. So what happened was that NAC went in there, and in the stage 3 meaningful use, which has not yet been published, but during the public comment period when they're getting ideas and suggestions and comments on what they're going to publish, that they, in part of the stage 3 meaningful use is the standards and interoperability longitudinal coordination of care work group and the specific recommendations for development of E-enabled care transitions. So what this means is in stage 3, what we're speculating, when they release stage 3, the new criteria will be that the physician EMRs and EHRs will have to have the ability to send data back and forth to other care providers that basically mimics a home health care plan of care. So it's not that home health has to have this in their software, because we're still not eligible to receive the money because we're not an eligible professional. We don't have the certification criteria. But what this means is that physicians, their systems will have to have the ability to send this data to home health softwares. So let's talk about that for a second. How is this all going to work in the real world? Do you think that your referral source, that let's say is a doctor that runs McKesson, and I've got another referral source from a doctor that runs a Cerner system, and I've got another referral source that runs eClinicalWorks, and another referral source that runs Allscripts? Does this mean that Allscripts, eClinicalWorks, Cerner, McKesson, and Healthcare Synergy, we're all going to get into a big room and say, guess what? Since we have to be interoperable, I'm going to open up my system so you can push and pull data directly into my database. Or you're going to open up your system so my application can push and pull data directly into your database. No, because we're closed-door systems. We're not going to allow for that. So the way that this is going to work is that we're going to have a tiered or a middle layer, if you'd say. And that is that each one of these software systems is going to be able to take data and send it back and forth in a standardized format. Very similar, if you think about it right now, to home health, about the OASIS. When we submit the OASIS, it's known as a B1. It's a standard application. If you're using Healthcare Synergy sends the B1 to the state. Before you used Healthcare Synergy, you used Haven. Haven sent the B1 to the state. The same thing happens, the same type of information. It's a standardized format we share back and forth. So with getting the electronic medical records to the EHR world, we're going to have the standardized formats. And that's why we were kind of excited about stage 3, because we see that there's now being set potentially a standard that us as home health and hospice can actually work with. Stage 1 and stage 2, we didn't have standards that would relate to our industry. So going back, now that we've got that standard of transmission, it doesn't mean that, I got that first picture that we're all kind of interoperability, that we're all crossing wires, and it's a big spaghetti mess. That's not realistic how it's going to happen. We're going to introduce the Health Information Exchange. And I always joke around, right now we also have Obamacare, which we're going to talk about in a little bit, or excuse me, I call it Obamacare, and I'm sorry if that offends you, but the new Affordable Care Act. We have the Health Information Exchange, which is an IT word, and we have Health Insurance Exchange, which is insurance. We're not going to be talking about the Health Insurance Exchange, so we're just talking Health Information Exchange. And what exactly is this? And it's basically two related concepts. It's a noun, which is an organization that provides services to enable the electronic sharing of health-related information. So in each state, there's probably 2 or 3 what's called HIEs that have started up, and they're basically organizations and companies, some of them are profit, some of them are nonprofit, that you as a provider can have a contract with, and you can send your data up from your system to them, and your physician can send their data up to them, and you'd be able to pull them back and forth. So they're acting as the middleman, as the communication method. So that's the noun. The verb is actually the electronic sharing of health-related information among organizations. So taking my EMR and putting it up there and combining it with, remember I talked about my very first example, my hospital, my primary care physician, and my skilled nursing facility, that would be the verb that the hospital is sending their information up and that I'm sending my information up. So that's the electronic sharing of health-related information among organizations. So that's what an HIE is about. And again, sometimes it gets confusing because we see the same acronym, HIE. We've seen a lot of emphasis on it now, talking about Health Insurance Exchange, which is completely different than the Health Information Exchange. So we got to have all those initials in there to have fun, right? So moving along, that's what a Health Information Exchange is. So let's talk about, you guys, a lot of people said that we had to be paperless by 2014. We had to be paperless by 2013 and 2015, and I don't know. Right now, on the law, there is no set date where we have to be paperless, where we're being mandated to be electronic. Where those dates apply are the cutoff criteria for the different meaningful use criteria for the eligible professionals, demonstrating the meaningful use. So for example, stage 3 meaningful use adoption will take place, and you need to have that in place by 2014 if you're an eligible professional. If you're an ONC, using ONC software. For us, again, in home health and hospice, unfortunately, this, I won't say mandate, but this incentive payments will not apply to us. So there is no date for us to be electronic or paperless. It's not being, you're not being forced by the government to be paperless by 2013, 14, or 15. So I'm sorry, those that answered, I don't have to be paperless, you win the prize. Email me. If you guys will email me and say, I said that you never have to do it, I will send you a USB thumb drive from Healthcare Synergy on that. So again, my email is mike.deck@healthcaresynergy.com. Email me your name, your agency address, and I will have a USB thumb drive from Healthcare Synergy sent out to you because you guys are correct. Sorry, guys. And I have the poll results, so I'll be able to go back and look on that. So you didn't know you were going to get a prize on this webinar. So what about ACOs? This is another popular term that has become more and more prevalent in our industry in the last, I would say the last year or so. And I'm not an expert on ACOs. I joke around. I stayed at a Holiday Inn last night with Arnie Cisnero. So that's where I get most of my information about the ACOs. ACO stands for Accountable Care Organization. And Arnie Cisnero is a consultant with Healthcare Synergy based in Michigan. And he has done a 3-part webinar that's available on our YouTube channel that really goes into depth and explains what the accountable care organizations are. So I'm not going to spend a lot of time on it. The website is there. And again, if you also want, I can send you a copy of this presentation. Either email me, mike.deck@healthcaresynergy.com, or email info@healthcaresynergy.com, and we can get you a copy of these slides. But this is a YouTube channel that Healthcare Synergy has. And a couple of things about the YouTube channel. Not only does it have this ACO webinar, which is a 3-part series from Arnie, there's also information. This presentation will be up there shortly. There's also videos on how to use the healthcare assistant. So if you haven't visited the YouTube channel, you can link to it from our website, or go ahead and just go into YouTube, user Healthcare Synergy. You're going to find a number of informational videos on there as well. So accountable care organizations. Accountable care organizations basically means that we're going to be looking at a new way of how we take care of our patients and how we get paid for our patients. And everybody's freaking out, and I kind of joke around, it's like everybody's freaking out when we had the PPS change as well. So it's at the very infancy, but what it means is that the ACO is based on the principle of monitoring patients' care to keep them from the hospital. You're going to have a one bundled payment system. So the ACO is a collective group. I like to think of it as like a government HMO. You're going to have ACO is going to have a couple of primary care physicians, DME, outpatient therapy, physical therapy, skilled nursing facility, and home health entity. And let's talk really quickly about our traditional care module that we have now. Let's say that I'm old and senile, which my wife says I am most of the time, but I'm older. I fall down, I have a hip replacement, break my hip. So I'm in the hospital, I have my surgery. And the hospital is going to go ahead then and send me to the skilled nursing facility upon discharge so I can get my therapy. So I can't go home. And the skilled nursing facility, well, they're going to keep me for what? 59 days, right? Because what happens on day 60, I have to start paying. Medicare is going to pays right now, I believe it's 59 days. And then after that, the skilled nursing facility will probably discharge me to home health. And then home health, you guys are going to keep me on for a full episode, right? Because that's the way that we use the current system. So there's a lot of waste on how we're providing care. I'm not saying that we're providing wasteful care, but we're spending a lot of money. Wouldn't it make sense to maybe send me directly from the hospital into a skilled nursing facility for maybe 5 days until I've recovered and I'm up and barely mobile, but I'm walking, because I'm going to go home, and then send in home health. So accountable care is going to be based on that principle of monitoring the patient's care to keep them from hospitalization. And I joke around ACOs. If you want to get involved in ACO, remember, LUPA will be your friend. You want to be able to prove that you're able to take care of patients better. So looking at the ACOs and the fact that you're not going to be the only one monitoring the patient's care, but the ACO that you belong to, they have a financial interest to make sure that you're providing the best care to the patient. So they're going to want to look at your documentation, your clinical documentation as well. So you got to look at how you're providing care now. How do you manage clinical documentation now? And I joke around, I've been around the block. I know a lot of us agencies that are on paper, you know, we really don't manage clinical documentation all that well, because it takes us 2 to 3 weeks to get that clinical document into our office. It says, hey, you know what, our clinician is out, they're out in the field, and a lot of times you probably get the text message or the email, hey, I can't drop off my documentation, I made these visits, don't forget to sign my paycheck for the 32 visits, love you, see you, drop off the documentation on Monday. And then you're getting documentation a week, 2 weeks, 3 weeks after the visit's been done. And when we start going into this ACO model, that's not going to work, because the ACO is going to want to know. Let's take a look at a congestive heart failure patient. And again, I joke around, I'm not a clinician. I'm married to an OBGYN. I just know certain examples. But congestive heart failure patient, if we see that the weight is gaining every single visit, we know something's going on, right? Well, if you're waiting 3 weeks to get the vital signs from that patient, it's not going to work in an ACO model, because by the time you see the trend, the patient's going back into the hospital. So we want to keep the patients out of the hospital. So the way that we base and do our clinical documentation is going to have to change. And we're going to hit resistance with our field staff. I guarantee it. And one of the things that, like an agency that I'm working with right now, one of the excuses or reasons that I tell them is, remember when you worked at the hospital? Would you go in and visit a patient and do their vitals and then go back to your desk in the center of the ward and sit down and go on Facebook and update your status and order Chinese food and go ahead and clock out and come in the next day and say, oh, you know what, I better enter that vital information for that patient from yesterday? No, we couldn't do that in the hospital. We've got to get that mindset again in home health, that even with our paper documentation, if you never wrote it down, it didn't happen. And I joke around, when I worked for an agency, documentation was due on Thursday. I used to see clinicians come in on a Wednesday before documentation, sit down in the conference room and fill out their visit notes. And it used to scare the bejeebers out of me, because me as an agency, I'm responsible for the clinical information they're putting on that form a week or 2 weeks after their visit. So we want to try to get our nurses, and we can even do it with paper, we want to get them into the mindset to document at the patient's point of care. And realistically, I know sometimes patients don't have the best working environments or living environments. We want to get into that house, and we want to get out of that house. Maybe there's an odor in there, we don't feel safe, we hear gunshots next door. You know, that's fine, but let's get the documentation done at least the day of the visit, not the 3, 4, 5, or even 1 week or 2 weeks after the visit. So putting the pieces together, when do I have to be electronic? Well, again, you aren't being forced to be electronic from the government, but as we move into this ACO world, this is something that we want to put on our radar. So again, the answer is, when do I have to be electronic? Right now, we want to start putting that on our radar. We don't need to rush out right away tomorrow and say, I got to get a paperless system, blah, 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 for my clinicians, and they have to do their documentation. So you know that's not going to happen. It's going to take a while to implement. But we want to start getting it on the radar because of the ACO involvement. if we want to be involved in ACOs, it's not going to be us looking at the clinical documentation, it's also going to be the ACO looking at the clinical documentation. So how does healthcare synergy interact and work with all this? And where do we go from here with healthcare synergy? So I apologize, one of the polls I was supposed to have up there is to see if you guys are already aware of or on Synergy in the Cloud. So traditionally right now, healthcare synergy, for many of you guys listening, you have the application installed on your server, and you also have the application installed on some of your desktops at your office. So in order for you to come in and use healthcare synergy, you have to physically come into your office, make sure your server's running, and fire up your desktop, click on the icon, and log in. Well, wouldn't it be great if I could be sitting on a plane at 30,000 feet, because I'm the administrator, and I could log in and look at healthcare synergy. And believe it or not, a lot of people didn't know we have that capability today, and it's called Synergy in the Cloud. So what happens is that we take your existing healthcare synergy application that you have now, and we actually migrate it up to what's called the cloud. And the cloud is just a fancy term for the internet, and that came from Cisco. So we take your database and we move it up to a secured, HIPAA secured and certified server, and we give you a web interface or a web portal that you go in and you launch the Healthcare Assistant. So you can take your Healthcare Synergy software that you have now installed in your office, and we can migrate it over to what's called Synergy in the Cloud. And that takes the Healthcare Assistant and now gives you the ability to access that software from anywhere that you have an internet access. So that's kind of stage one of where we're going. And this has been out since January of 2012 is when we first released it. We actually had beta users in November and October of 2011. So it's not a new thing from Healthcare Synergy, but that's what it means, is that we can take your Healthcare Synergy and move it up to the cloud. Now the nice thing is this is not a new application. So your existing data that you have with Healthcare Synergy, when we migrate to Synergy in the Cloud, it's a light switch for you. One day you're using your normal, what we call the legacy version of Synergy. You flip the switch. The next day you go to the website, you log in, you click on the icon, and you're using the cloud-based version of Healthcare Synergy. And it's the same database. So there's no re-entering data. You don't have to transfer patients from back and forth. So that's kind of step one, where we go from here. Now on top of that, Healthcare Assistant does not have an integrated point-of-care module. We've been relying on our partners, Global Reliance, DeVero, and Care Portal. So those are our options that are available for you today. If you want to use the Healthcare Assistant software for your billing practice, you can look at the eClinical software, which will also run in the cloud, and also DeVero. And then we also, for those agencies that want an all-in-one solution, we offer the care, we partner with the Golden Rule software and look at the Care Portal system. So again, that's for the agencies that want to implement a point-of-care module with their Healthcare Synergy application today. But we all know that times are changing and things are changing. So where are we going from here? Well, the future, it's in beta. And we talked about how we moved your Healthcare Synergy up to the cloud, and that was kind of like stage one. Remember I said that? Well, now we have what's called the Healthcare Assistant Web Edition. And it's going to be available very soon. It's released in beta right now. And if you're interested in this, send me an email at mike.deck@healthcaresynergy.com or beta, B-E-T-A, at healthcaresynergy.com, and I can give you more information. But basically it means that we have a whole new web-based system that will interface with your same database. So again, it's a migration path. It's not a conversion from one program to the other. And I will be glad to talk to you about this web-based version. But if you imagine that I'm talking to you about the health information exchanges, the ACOs, and the web-based version, you're going to see that we are keeping an eye on this, and we are developing the web-based version, keeping those standards and those changes in effect and in mind. So with that, we're going to go ahead and see if there are any questions. And there are, but I can't read them. I'm joking. How do I do this? I apologize about that. I'm going to have Joe, I'm going to move here for a second. He's going to expand it. do a large number of high-risk pre-post-medical patients. Okay. Somebody was just telling me that they're doing a number of high-risk OBGYN patients. So come on back. If you do have any questions, go ahead and type them in. I'm going to go ahead and come back to my home screen of this presentation, which is home. And make sure that oh, it's going to want to go all the way back. I apologize. And make sure that you have my email and my phone number up there. Again, the email is Mike, M-I-K-E.D-E-C-K at healthcaresynergy.com. And I can be reached at the Healthcare Synergy offices at 714-229-8700. My direct extension is 321. So we did get a question, can I switch back to server-based Synergy from the cloud Synergy? Absolutely. Since it's the same database, you can migrate from one to the other if you want. Now, I'll be honest with you, there are a number of benefits to the cloud that outweigh the legacy. And one of those benefits is the fact that you are eligible for the beta for the web-based version, but the capability. The stance of Healthcare Synergy, and let's talk about this for a quick second, is that it's a lot of software providers take the stance that when you use our system, you're using software as a service. And when you discontinue the service with us, it's over. Healthcare Synergy, your database is your property, is your data. It doesn't belong to us. So if you want to migrate from whatever system you're using, it's your data. So absolutely, you can do that. And so now I'm getting a couple of questions about what's the cost of the cloud-based system. And the best way I can answer that is to please email me. I can let you know it is not as expensive as people think. There's a little bit of an additional charge. But the reason why I can't give out hard numbers is because Healthcare Synergy has a rental, a lease, and an own application, as well as a number of user that you currently have. So let's say I'm a small agency that's running the software for one user. Well, that cost is going to be a little bit different than a large agency that's leasing the software for 50 users. So I can't really give out the cost of it. I can let you know that it's not much more than what you're currently paying for on Healthcare Synergy. If you're interested in that, shoot me an email, mike.deck@healthcaresynergy.com, and I will, or if you want to, Evelyn, E-V-E-L-Y-N, at healthcaresynergy.com. Or give us a call directly here at 714-229-8700. Ask for the marketing department, and we will be able to get those numbers for you. So I apologize that I can't give you the exact numbers of the cost of the cloud-based system at this stage, but it's going to be based on the number of concurrent users. Now, the next question will be, what will be the cost of the web system when it comes out? Because we want to make sure that, we're not going to be charging more than that. And on that one, I will tell you that we will have hard numbers by the end of this week for that. And it will also, again, be very comparable to what you're paying for the cloud services. So it's not going to be that we're going to say, oh, here's the brand new system with all these additional features, and we're going to charge you $2,000 more a month. No, it's going to be comparable to what you're paying right now. Okay. Do we have any other questions? And I'll go ahead and give it a second here and see if we do. Okay. Since we don't, I'll go ahead and wrap it up a little bit early. So if you're on the West Coast, you can go ahead and start lunch because it's 11:45. And if you're on the East Coast, you can go back to working because it's 2:45. It's almost quitting time. Again, if you have any questions on this presentation, we're going to have it up on the YouTube channel here shortly, probably within a week or so. If you are in Ohio, we have a free Healthcare Synergy user meeting at Bravo and Easton in Columbus on Tuesday, May 14th. Please give us a call and get registered for that. It is free. We do ask for a credit card just in case you don't show up because we'll be providing you with a meal. If you're in the Chicago area, on June 18th, we will also be having a free user meeting dealing with Medicare billing, the HITECH Act, the EMR, EHR, tips and tricks on how to use the Healthcare Synergy application, everything that our user meetings are known for. That's going to be at the Maggiano's in Oak Brook on June 18th. Look for the invite coming out soon. And if you're in the Southeast Michigan, on June 20th, we will be having another another user event as well. Again, free user meeting. And we've got another issue, or another question come up. Will you be sending the PowerPoint slides to the attendees? And absolutely, if you want a copy of the PowerPoint slides, just please shoot me an email at mike.deck@healthcaresynergy.com, and I'll send those to you as well. And then we've got another question that popped up. Have the billing issues been addressed, transfer to ability, etc.? And Sally, if you can, shoot. I'm going to have somebody call you directly from Healthcare Synergy on those as well. So Sally, stand by here shortly. I'm going to have one of our representatives give you a quick call because I'm not quite sure which issues you were talking about and maybe an industry perspective or independent issues. So we're going to go ahead and have an agency or have a representative give you a call. So once again, I thank you for the opportunity to spend a little bit of your afternoon with me. And go ahead again if we've got those events in Columbus, Chicago, and Michigan. And also, if my little radar told me correctly, we will be doing one here in Cyprus sometime the first or second week in June. So I'll be out there as well. Thank you once again, and have a great day.